Welcome to the Healing Pain Podcast with Dr. Joe Tata. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tata.
Hey there, friends. Welcome to this week's episode of the Healing Pain Podcast, the show where we explore the dynamic world of chronic pain, neuroscience, physical therapy, and the opportunities for transforming how pain care is delivered. I'm your host, Dr. Joe Tata, CEO of the Integrative Pain Science Institute, where we train physical therapists and other practitioners on integrative whole-person pain care. Our featured guest this week is Dr. Afton Hassett, a licensed clinical psychologist and director of the Pain and Opioid Research Center at the University of Michigan. Dr. Hassett's work in the Chronic Pain and Fatigue Research Center has made her a prominent figure in the field of pain management. With over 100 articles published in scientific journals, Dr. Hassett focuses on exploring the profound impact of positive emotions on people living with chronic pain, while also developing interventions to enhance pain self-management. Dr. Hassett's contributions go beyond her research. In addition to her academic accomplishments, she is the author of a new book called The Chronic Pain Reset, 30 Days of Activities, Practices, and Skills to Help You Thrive. Okay, without further ado, let's begin and let's meet Dr. Afton Hassett and learn about effective strategies for pain self-management. Hi there, Afton. Thanks for joining me this week on the Healing Pain Podcast.
Oh, hi, Joe. I'm so happy to be here. Thank you for the invitation.
I'm excited to speak with you a little bit about the psychology of pain and all the things that, really are connected to that. The biological piece, the sociological piece, the environmental piece, what's happening in our healthcare system, new developments that you're working on, things that we may or may not be focusing on that we need to focus on more. So I know we're going to touch on lots of topics. I think a good place to start, because a lot of what you do revolves around researching pain, right?
Right.
At the University of Michigan, I know you and your team work on that on a daily basis, and you have a number of research investigations going on. Tell us, I think a good place to start is, what's the one thing you're working on as far as research goes that you're most excited about?
Oh, so actually, I love so many things, so it's hard to pin one down, but I think maybe the one that may have the biggest impact and really will, I think, hopefully impact physical therapists is a study that we're conducting under the HEAL NIH funding initiative, and that's Help End Addiction Long-Term. It's the congressional money that was put forward to really support, hopefully, some innovative research in substance use, but also in pain. And so the grant that we had gotten is what they call a mechanistic research center grant, which just means it's a big bunch of money to really, really dig into a topic. And so what our group does phenomenally well is mechanistic work. So understanding, teasing apart the brain mechanisms of things, how inflammation works in the body, how treatments impact brain function and other biological changes. And so what we're doing is we're looking at 4 effective treatments that are commonly used in chronic low back pain and really trying to tease out 2 key questions. The first question is, who responds to what therapy? So given therapies that are evidence-based and generally effective, because they only work for about a third of people in many cases, who responds best to what therapy? Can we learn anything about ordering? So, for example, would we want to get patients on duloxetine before sending them to physical therapy, or do we want them in physical therapy before we have them do a talk therapy? Those are some of the questions we can answer. But because we're a mechanistic center, we can also dive into how are these working, right? Is physical therapy changing connectivity in the brain? Is duloxetine affecting different systems than we thought in the brain, or inflammatory systems? Are behavioral therapies different in how they impact the overall physiology compared to physical therapy? So it's really exciting. And we almost are overwhelmed by the data that we're getting already and how to, really best tease out these really key relationships.
So the focus there are pain mechanisms, so to speak, right? And
yes.
Maybe just for people listening who may not know what a pain mechanism is, maybe just kind of distill that down. Like, what's the difference between research that looks at pain mechanisms and why that's important versus research that maybe looks at outcomes of the research, so to speak.
Oh yeah. So yeah, I kind of struggle with this. It's like, why would we really care how something works in the body? Why is that important? Isn't it just important that it works? I think when we understand the mechanisms, it helps us make it clear that this behavioral treatment, whatever it might be, is actually changing body and physiology. And I think then it becomes even more compelling to physicians, especially that, oh my gosh, if physical therapy is literally changing connectivity in the brain, wow, right? So those are the types of things that gives us a little bang for the buck, right? But what the research that we spend a lot of time on are the mechanisms of pain itself. So understanding the differences amongst types of pain. So like an inflammatory pain is quite different than a mechanical pain, kind of bone-on-bone osteoarthritis. Versus a pain that is predominantly driven by dysfunctions in the brain, so changes in the function and structure of the brain, so like a nosoplastic pain. And all of those require different types of treatment approaches. And when the pain types overlap, say an inflammatory pain that also has a nosoplastic, so somebody's rheumatoid arthritis and fibromyalgia, how that is treated so differently. So, really kind of being able to tease apart some of the biology of these things does really give us some important information.
And just review us the four groups that you're looking at. You mentioned were
physical therapy, mindfulness-based stress reduction, a group, kind of an online group a setting. We're looking at acupressure delivered by mHealth, so kind of a self-acupressure regimen, and then lastly, duloxetine.
Interesting. So I'm curious about this. So as you know, a lot of physical therapists follow this podcast. So one group is quote unquote physical therapy. To me, physical therapy is a profession, not an intervention. So I'm wondering how, what that particular treatment looks like, how you're standardizing that care there.
That was our hardest.
How the physical therapist is standardizing.
That was our hardest arm. We spent the most time talking about that because exactly what you're saying. And it's many things, right? And so I think almost like psychology or many interventions, one size doesn't fit all. So how do you come up with a plausible intervention that is tailored to some degree, but also meets the needs of conducting a clinical trial? So we worked very closely with a number of DPT level individuals that kind of gave their feedback, and then we also left a lot of latitude. And so, unlike most of the clinical trials that we conduct that are really pretty to the letter, we left physical therapy to be more flexible because that really is kind of the requirement, right? The physical therapist has to make this assessment and really, truly use different tools in the toolbox to be able to best treat the patient. So we left that pretty loose. And so one person's physical therapy may not look like another one in this study. And we're very clear about that because we also wanted to, because it's a mechanistic study and not an efficacy trial, meaning that we just want to understand how stuff works. We wanted to kind of represent what really happens in the wild, right? That, you guys aren't following one treatment manual. You really are adjusting. And so, there were some parameters like, and we're doing long visits too. And so they're doing 30-minute or longer visits. And then they're getting eight sessions. So it is what I hope is a reasonable dose of physical therapy. What we've asked them not to do is something that you guys probably do regularly and do very well, is add a lot of the psychological aspects to it. And that's just for this study. In a separate study, we are allowing that.
Interesting. Okay. So you did piece out kind of the psychological aspects. It's interesting though, because, as I mentioned, physical therapy is a profession. So we do a lot of different things, just like, psychologists, quote unquote, do a lot of different things in therapy. Some people actually look at movement as a behavior. Like it's almost like its own behavioral therapy. And when I think about it like that, like when I reflect back on the research that has been done in neurological physical therapy with people recovering from strokes and Parkinson's, we know that there are changes happening in the brain and nervous system. It's neuroplasticity, it's motor learning, it's motor control, those aspects of things. Are you starting to see that? Can you share a little bit of early data with us in that area?
We don't have it yet. I would love to scoop some of it to you, but yeah, no, we're still in early days. We're still cleaning our neuroimaging data, and so we have made good progress. So we want to randomize a total of 400 individuals, so 100 in each arm of the study. We're at 300 now, so we're not all that far away. We've made great progress. So hopefully we're going to have some preliminary results for you in the next year.
Okay, great. And I know you also are working on some neuroimaging. I know it's probably part of that study, but are there other? Is there a neuroimaging study that has come out of your group that you'd like to share with us that is really important with regard to kind of what we're seeing happen in the brain with pain?
Yeah, I think. I don't know if I want to stay close or go all the way back. So our group I'll do both. Our group is very known for a study actually that was published back in 2002. And it really was the first study that showed using neuroimaging that there are differences in the brain amongst people who have chronic pain compared to those who do not. And in this study, they compared people with fibromyalgia to a non-chronic pain control group. And what was seen in that study was that the individuals with chronic pain required far less pressure pain to have a very similar neural pattern to the people who had chronic pain. So we had actually put 6 times greater pressure pain on the healthy controls to get the same level of brain activation. So that was really the first time it kind of was shown in a real clear fashion that something is different is happening, that there is this amplification process. But a second study I want to tell you about is something we published rather recently, and it's using the ABCD data. I don't know if you talked about that before, but it's a fascinating, another NIH initiative to study a large cohort of children over time. And so they're studying these children in very in-depth ways, starting, I believe, at 8 years old, all the way through the end of the teen years, and looking at questionnaire data, but also they do neuroimaging every year. And so you can map that data on. And the study was initiated to understand substance abuse. Which children are particularly vulnerable to developing substance abuse. But in it, they also ask questions about pain. And so we were able to use those data to ask them questions about, given pain-free children in an early stage, what really predicts the onset of new pain down the road as a teenager? We see many of these pain conditions actually begin quite early and then, last into adulthood. And what we found was quite surprising in a pair of papers. So the one paper that looked at the questionnaire data, it was not depression and anxiety that was predictive of who got chronic pain. As we may think or might hypothesize that could be a predicting process, but it really was kind of sensitivity to body, to being aware of body, feeling, smell, senses, having a few symptoms, and sleep problems and cognitive problems. The kids with kind of the greatest kind of cognitive complaints and fogginess were the ones most likely to develop chronic pain. And then in the brain, what we saw that really was exciting was that the children who had intense or overconnectivity between the default mode network and the salience network, which is something we see, these two networks in the brain are overconnected in chronic pain adults. In children who have the same connectivity pattern of these two networks, they were the ones that eventually developed chronic pain. So it's like, wow, this brain connectivity is a vulnerability. It isn't necessarily caused by the experience of chronic pain because we didn't really know. So that's just some exciting work that I think helps us, kind of think about these conditions a little differently.
Opioids are a sensitive topic.
Yeah.
We've talked about opioids over the years. Sometimes I've done entire episodes on them, and I oftentimes receive very positive feedback. And then I oftentimes receive feedback from people who are concerned, they're scared, they're angry, right? All very understandable reactions to opioid use and misuse at times in our nation, and how all of us, and I include myself when I say that, how all of us have approached this topic and how we're still trying to figure out, what this topic is and how to help people directly. What's your, and especially within the last year, kind of some of the restrictions around opioids have been slowly kind of, pulled back a little bit so that prescribers would have a little bit more flexibility that was taken away from them. And I have, I think probably like yourself, I have mixed feelings around some of these things. Some of the 2020, 2030 healthy people data shows that emergency visits for opioid misuse is actually down, which is good. So I'm concerned if we roll this back, might we see that go up? But what's your general kind of opinion, I guess? And, obviously this is a professional opinion about where we are as far as opioids and what we should be communicating to the public about the use of opioids.
Yeah. Oh, it's sticky subject because part of it is the data aren't that good, right? The really definitive clinical trials have not been conducted. And so what we are kind of left with is what we see clinically. And so our research team is embedded in a very large outpatient pain clinic for the Department of Anesthesiology at the University of Michigan. And we see 2,000 new patients a year. So it's a busy clinic with many individuals, and a large number of individuals come into our clinic on opioids. And so the question is, what do we do? Do we continue these? Do we discontinue them? It's hard because what I know in talking to physicians and talking to patients, some patients with chronic pain actually do well with opioids. Some do. And you take them off of opioids and they're miserable. And I think that it started a panic and a lot of fear and a lot of anger, rightly so, to have a medication taken away from me that really works. But then we also see a group of patients that the opioids are not helping, and their lives are could be disrupted by addiction. That's almost more rare than when we see that they're just not benefiting, that people are coming in on a large dose of opioids and their pain is a 7. And so some of the work that we've done is also trying to understand the phenomenon of opioid-induced hyperalgesia, which is the notion that your body acclimates to whatever's put into it and changes, and can actually, in the case of opioids being taken for too long a time, actually make pain worse. So the use of opioids is actually elevating pain. So we don't really have a great way of knowing that just by looking at the patient. And so we often think that, you're taking opioids, you've been on them a long time, you probably don't remember what it was like to be off of them, but what might be happening now. And we talk to them and saying, a large subset of patients do as well or better off opioids, but we won't know what patient you are. And if you do terrible off of opioids, we will figure out how to get you back on opioids in the same way, et cetera. So the opioid experiment is amazing because most people are afraid to do it because they can't believe that their pain could possibly be better. How could it? Right? It's going to be a 62 if it's a 7 on opioids. But what we find is that as they're weaned off of opioids, often using help of buprenorphine or other types of weaning medications, that after a few weeks off of opioids, a large subset of patients are shocked that their pain is actually better. Shocked. And they're sleeping better. Their emotions are feeling more stabilized. They're thinking more clearly. They're able to go to the bathroom. I mean, life has just gotten better. And so I think a sane way is for each patient to meet with their physician and decide if an opioid experiment makes sense for them, and just kind of see where they're at. And so I think, I think we need to be sane, and I think we need to recognize that some people do benefit, and it's a disservice to just stop giving people opioids, and it's dangerous.
Right. Of course, we know. I mean, what we do know is that it can be dangerous, right? That's for certain. And I definitely appreciate your point. And I'm sure people listening who are on an opioid or have taken one in the past and benefited from it, that some people do show beneficial effects from it and other people don't. Yeah. Talk to me about how important in that process choice is. Mm-hmm. With regard to the conversation around tapering.
Mm-hmm. I think it's critical. I think it's like anything else, unless somebody is at that inflection point where they want to explore something different. I think you can't make people do things. I think it is so difficult because they're going to have a bad outcome. But I think that if we educate and people think, what, on the other end of this, I might be better. Isn't that worth seeing? It's cracking open that door that I might be better. And if not, I can go back. I think that's it. And I think choice is critical. It's studies that we often conduct that the more choice we give to patients and kind of what they do or when they do it, the better off they are. And it's a huge piece of my book that when I talk to other clinicians about, hey, what behavioral therapy or what therapy in general works best for patients that you treat, and we all come to the same conclusion. The treatment that works best for almost any given patient is the one they're actually willing to do. Right. And, and again, it's because if something makes sense to people, if it feels like it's something that they can do, it's doable, then you're much more likely to have, a good outcome. I'm a terrible patient if I don't understand why something is being asked of me by my physician. I just won't do it.
I think most of us in healthcare are like that. We want a lot of information first, and then we want to make an informed decision. But for some reason, in our busy healthcare system, we at times don't afford that luxury to people. And I think with people with pain, especially, they've been through 2, 3, 5, 10 different providers, and now they want to know, okay, what's different about this particular encounter, and how is it going to help me? Just to talk about a little bit of the data around the tapering.
Mm-hmm.
Do we have an idea? Because I've seen obviously slow tapering schedules. I've seen fast tapering schedules. And then I've seen some data about tapering with giving people different types of tools. And that could be anything from exercise to mindfulness to, pain coping skills, et cetera. Do we have any idea how we should really approach the safe, effective, and shall I say comfortable tapering for people? Because there's a comfort level here that I think has to happen as well.
I think it's right. And I don't know what the actual data are. I know what my observations are, is that I don't think you can take anything away from somebody and not give them something else. Right. And so it's, I think it's really critical that we offer, okay, we're going to give you some other tools, right? We give some other medications, and we're going to provide for you some additional behavioral things that you can do to, kind of unlock.
And that was a problem in the early opioid crisis, probably back around 18, right? We just kind of pulled the rug out.
Pulled the rug out and, take some Tylenol. It's like, that doesn't work. And I got nothing else. So, I think it's critical. And you know what? I think the data will eventually catch up, because I think that everybody kind of, even the CDC, kind of said, okay, let's rethink what we've stated here. Yeah.
Do you think, of course, looking back, as you mentioned, we don't have a lot of data on certain topics. I think the idea of, kind of pulling people off the opioids rapidly in many ways was done with a good intention for the most part. I wonder how much or how many people, shall we say, did we inadvertently traumatize through that experience, and how important that is from the trauma-informed lens of working with people who have pain.
Yeah, that's so cool, Joe. I haven't really thought about that from that perspective, but it would be traumatic, right? And, the very people that you trust, your healthcare providers, perpetrated this trauma. Yeah. Is this something you've observed? I think that's a really insightful thought.
Well, I think a lot of my interest recently is around not how we educate people, because I think we've gone down that road, and especially in the world of PT, pain education, we have quote unquote used education as an intervention. Yeah. But my question is, with the particular person in front of you, because pain is contextual, right? Specific to the individual. What do they need so that they feel empowered?
Right.
Right.
Yeah. Well, is it knowledge, but also choice?
Yeah.
And I think it's both of them. And that, and I think it's true for most kind of big decisions, that sometimes if you lay things out there and just let people chew on them for a little bit, let them talk to people, let them think about it a little bit, and then give them kind of the list, what are the potential symptoms? Let's talk about this together. What are your kind of concerns, and it could be cognitive fogginess, it could be constipation, whatever it could be. And just, think, how do you weigh those? What would you give to get them back? Yeah. And, I think, kind of this motivational interviewing approach can be really effective, just to kind of figure out, what are kind of the barriers and the facilitators, and, and I think it's also sometimes people just need a little time.
Yeah. The other piece, as far as the trauma component there, is which we hear in pain all the time, is this idea of safety.
Yeah.
And I'm always thinking, okay, does this person feel safe in their body?
Yeah.
Do they feel safe in their mind? Do they feel safe in the living environment that they're embedded in? And potentially what's important is, do they feel safe with us as clinicians engaging in that therapeutic encounter? And again, when we take an intervention and we pull it away, and this happens with insurance companies too, like all of a sudden insurance companies will be like, oh, sorry, no more psychological services for you, no more physical therapy for you. And it's an abrupt change in someone's life as they were starting to build that sense of empowerment, that sense of safety, that sense of self-efficacy, that sense of, wow, this can actually get better.
Yeah. And how do we restore that? Right. And I think it is, often it is just acknowledging, I think that's a really big piece of it, that to put on our kind of our little psychology hats and realize that there probably was something there, that there probably is a little bit of a trauma there, and acknowledging how hard that must have been for them and how hard it must be for you to trust me now, and that, and not even initiating, I think, anything until the patient, has a greater sense of trust in you too, because the last thing we want to do is to yank out the rug again from them. And I think also helping them determine what are the other pieces that they need to feel safe. Is it having a rescue medication? Is it having a plan for what might happen if they develop other types of side effects? Is it a group that they can talk to? Do they need more humans in their lives to help support them through this? So I think just really identifying what it is that's going to help them feel safe is really important.
Yeah, really well said. Obviously, as a psychologist, cognitive behavioral therapy is something that interests you, that you use, that you've been researching. A lot of other professionals are using cognitive behavioral techniques and skills as well. There have been a number of large-scale meta-reviews on cognitive behavioral therapy for pain. As you mentioned very early in today's episode, pretty much anything you look at helps about a third of the people.
Yeah.
And the other 2/3, not really so much, low impact, so to speak. Tell us how you view cognitive behavioral therapy for pain. What do you see is missing, and how can we bolster that in a way that could potentially be more effective?
I think, CBT for pain has strengths. I love that it's very portable. It's like, many people can deliver this to their patients. A lot of it's very behavioral. It's very clear. And many of the techniques are evidence-based. So I think that is kind of a big pro. As a practitioner, in the past, what I've also found, though, is it's kind of lacking something. So there's a little bit less emphasis on kind of the emotional aspects of living with pain and what that's done to people's relationships and lives and self-esteem, safety, that sometimes there are deeper issues that need to be addressed to help the person. It might not, necessarily just be impacting the pain. It could very well be impacting their overall mental health. And so that sometimes is missed in cognitive behavioral therapy for pain. And that one of the major things that we tend to see, in research and clinical practice, is that many people with chronic pain are leading lives that aren't feeling terribly fulfilling. They're kind of surviving and getting by and doing the things that they have to do and addressing the must-dos in life, and missing what Los Verbrugge called valued life activities, kind of the things that make life sparkle, right? The things you care about. And those just get set aside. And so an element that I really care about in making cognitive behavioral therapy more effective is getting at some of these affective elements by predominantly, decreasing negative emotions, but really building positive emotions in an effort to kind of build resilience, and to even think about how we deal with kind of the reward processing deficit. So there is kind of this brain pattern that we see where there is deficits in the reward processing areas of the brain, but those are reversible, as some new data are starting to show that just by doing simple positive reinforcing activities regularly, these systems start popping back online. And so the tact I take then is, let's integrate some of what we've learned in positive psychology that also has an evidence base to it, and not only make the CBT richer and perhaps hit more targets, but also make it more engaging. Because again, what we all struggle with is how to get people to continue to do these things we introduce them to, and maintain them over time, so that they can continue kind of their emotional fitness over time.
Interesting. So I want to unpack a couple of things there for the clinicians, probably mostly, but for people who are interested in CBT as well. When you and I are talking about the kind of the data behind CBT, usually we're talking about, a package of, let's say, 8 to maybe 10 or 12 sessions, right? And I think in the beginning, when you said that you're a proponent of CBT, except you feel that there's the affective component that's missing. So when I think of that, because we're talking about CBT specifically for pain, which typically has a focus on negative thoughts, shall we just say, and working with negative thoughts. And sometimes when you work with negative thoughts, it does obviously have an effect on emotions. But you're saying, how can we be more intentional about improving someone's affective response to the way they're living?
Yeah, exactly. And how do we identify what are these person's priorities, and how do we help them integrate more of this in their life? Because not only do we find that when people are engaged in things they enjoy, they're actually moving. Because one of the real secrets of positive psychology interventions is that they have behavioral activation at their core. And so, getting people to do pleasant activity scheduling, which is part of CBT for pain, is really valuable because, again, it's activating. We're getting people to move and do things. And when we do studies of CBT, that's the one thing that we find people do the most. That, if we assign all these other types of activities, that's the one thing people get all in on. Because it's like, oh my God, finally somebody's giving me permission to take time for myself and do things that I value. So yeah, so I think that, by really kind of keying on that and giving people the space and the opportunities to have some joy again, and it's it really does help. It really does help with pain, with people's experience of pain.
So CBT delivered with a strong behavioral activation, kind of lean into it, if you will, right? Yeah,
lean into it and lean into the resilience aspects of it.
Can you tell us like what you're kind of, when you say behavioral activation, what does that mean to you? What's the definition? What are you really saying with that piece there?
That piece is saying we see a lot of restricted movement in chronic pain, right? So there's often fear of actually movement, but there's also a lot of fear around doing things. If I get out there in the world and I I'll have to sit down, or my friends are going to be disappointed, or, I don't know if I really, really am in a space where I can start this hobby, or take up my hobby again. And so people their world shrinks and they withdraw, and their worlds become very, very small. So the behavioral activation part of it is, beneficial in as much as it gets people moving again physically, but really emotionally, and being engaging in life again. So it's a different than the real kind of true definition of behavioral activation. It is more broadly that just getting people moving again and re-engaged in things that matter to them.
Yeah, because behavioral activation kind of came out of the depression research, and then has been kind of modified and molded a little bit for chronic pain in a certain way. It's interesting because when I read the behavioral activation research and I really kind of sit back and think about it, I'm like, a lot of this fits into what I would consider really good physical therapy.
Yeah,
where exactly. You're not just giving someone an exercise for the sake of an exercise. You maybe give them an exercise, but you're talking to them about, okay, now how do we apply this movement to your life? And where would you use this type of movement? How is movement important to you in the sense that it's going to help you re-engage with something that is important, meaningful, maybe has a sense of purpose to you and value in your life. All those things I think are rich, as you mentioned, in the emotional and affective component of things.
Yeah, I love that. And I think that is so key. And part of what I talk about frequently when I'm working with patients, and and they talk about in the book, is that really the team is so important. Working with the physician, working with the physical therapist, working with potentially a behaviorist, that it is so important. And then if we can all kind of come together, because I love your interpretation, and that is so key, that this movement is not just a movement for movement's sake. By strengthening and being able to do this, then this might open the door to you doing, taking a pickleball again, whatever it is that you absolutely adore, and it just clicks for them that, okay, I'm willing to do this now. I get it.
Pickleball is a great example. Everyone's doing that now, right?
It is, but it's so social too. And so I think that's really an important piece of building resilience and helping people, get behaviorally activated, get re-engaged.
Yeah. So I know you've wrapped up a lot of this research in a new book you have that educates people about chronic pain and the safe and effective ways that they can obviously manage it and eventually overcome it. I'm sure you've read many books in the past. When you started to look at some of the trade books, if you will, that are out there on pain, what did you find that was missing in them that you included in your book?
So actually, there are a lot of good Black books out there. Rachel Zoffness has a lovely book out there. I mean, there's just a number of them, kind of depending on where we're going. I think for me, the key was, how do you help a person maintain the changes, right? So I think a big problem that we see in many self-help books is you read them, think, that's really kind of cool and interesting. And then the person reading it never takes a step towards actually practicing what they learned. They have that knowledge and maybe someday they'll come back to it, but it's not terribly actionable. And so I try to make a really actionable book. And so I just start with, a series of chapters that really talk about some of the neuroscience, and hopefully in a very accessible way, but also the neuroscience that kind of underlies thoughts and emotions, and then just the data and the support for the importance of things like gratitude, our social relationships, having a sense of purpose in life, that all of these things are really valuable and actually have benefit for chronic pain at the behavioral, at the psychological, the social, and also the behavioral, the brain level. And so once they kind of get past, and hopefully I've set the foundation for why I'm going to ask people to do some really weird stuff over the next 30 days. And so the meat of the book is 30 activity, skills, and practices. And so it's a little like speed dating. So each day I say, just read 2 pages. And the 2 pages are a new skill, activity, and practice. It's evidence-based. And read about it, give it a try during the day. And at the end of the day, think, did I like this? Is this something I can do in my life? Maybe. Maybe the next day is the one that they love. And so they can start that, say, you know what, this is so much more mindful breathing. That I'm all about mindful breathing. To another person, though, mindful breathing is going to seem like a bunch of hooey. And they're going to say, that's stupid. I don't want to do mindful breathing. Thank you very much. But each of these practices are very, very different. Very, very, very different, not necessarily from each other, but from they tap into different categories, right? So there's a lot of emphasis on moving. I love people to start a walking program. I love people to get into nature. I mean, that's some of the things. But at the end of the 30 days, they've read about and tried different interventions for thoughts, for emotions, for relationships. And at the end of the 30 days, they come back and they take stock. What were the activity, skills, and practices that felt like I really like? Did these speak to me? They make sense in the context of how I understand my pain. And I'd actually be willing to do them. Mm-hmm. And then the last part of the book just helps them build a real incremental plan, kind of trying one at a time, give it a couple of weeks to see if they really want to make it a habit. How do you make it a habit? When do you introduce something new, another practice? So maybe somebody starts with a walking program, but also likes being in nature, so they can kind of combine those 2 things. And then maybe they also want to start a gratitude practice a week, and that's okay. We just try and do things incrementally. And so they're hopefully building a richness in our life that hits a number of domains. We want people to sleep better. We want people to move. We want people to have richer relationships. We want people to feel that they have some stress coping techniques.
Awesome. I think that a lot of good things I want to just kind of point people to is one, always think about hitting a number of different domains, right? And that doesn't necessarily mean interventions.
Right.
That means that there's got to be something physical to what you're doing. There should be something that has like an emotional, psychological component to it. There should be something that's social. There should be something that's lifestyle based. Those are typical domains that we're looking at.
And thoughts. Yeah.
And then like yourself, I've read a lot of self-help books on pain. And what I find is they're huge, right? They're like 300 plus pages. And my question always is, who's reading this and doing this whole book, right? Because most of us with, advanced degrees probably would have a hard time picking that up. So I think the idea of just, one little thing a day, you have 2 pages in your chapter, which I did the same thing in my book, Radical Relief. It's just 2 pages a chapter, something really small. And I think kind of where you're going with that to kind of connect to the neuroscience is neuroplasticity works. When you have something that's achievable, it's small, but you can do it frequently.
Yeah, it's right on the mark, and I want it to feel doable. And I had a lovely editor who kept shortening.
Yeah, that's right.
You're right. You're going to help me write this more brief, because people with chronic pain, it's hard for them often to read. And actually, I've got the audiobook is going to be out at the end of the month, so I'm so excited about that. Exie Sands is just a fabulous narrator, so she'll be doing that, and I think that'll be helpful too, because some people with chronic pain find it just really hard to read it. It can spark a migraine. It can feel fatiguing, and just to hear the spoken word is often superior.
Beautiful. So we will point people, of course, to your website. You tell people what your website is and the name of the book.
Sure. The website is aftonhassett.com, AFtonHassett.com. And the book is called Chronic Pain Reset, 30 Days of Activities, Skills, and Practices to Help You Thrive.
Excellent. So I want to thank Afton for joining us today to talk about chronic pain, both the research behind it, as well as the practical solutions that you can implement into your life. You can find her book where all books are sold, online or in a store. And of course, you can go to her website, aftonhassett.com. Those links will be included on the page over at the Integrative Pain Science Institute.com. Again, I want to thank Dr. Hassett for joining us this week with some really wonderful information around how to treat chronic pain safely and effectively. I'm Dr. Joe Tata. And of course, please share this episode with your friends, family, and colleagues on your favorite social media handle. Hop on over to the Integrative Pain Science Institute and join our mailing list so you can receive the latest episode. And we'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tata. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.